So good evening, everybody. I welcome all of you to the Cutting Edge webinar, which is by the Pune Obstetrics and Gynec Society. This was initiated by Dr. Meenu Agarwal, madam, and we have been successfully running this series every Tuesday evening. So I welcome all of you. We are very honored to have all of you all here, and I request Charu ma'am to introduce everybody and welcome them for the lamp lighting.
Yeah, so good afternoon, everybody. Thank you so much for joining in spite of your busy schedules. We are blessed to have the Mumbai OBGYN Society with us today. And we would like to proudly welcome our chief guest for today's webinar, Dr. Nandita Palshetkar, madam, our guests of honor, Dr. Neeraj Jadhav and Dr. Sanjay Patel, and of course, our esteemed faculty in the form of Dr. Anahita Chauhan, ma'am, Dr. Gaurav Desai, Dr. Preeti Vyas, Dr. Gautam Sonavane, and the rest of the Mumbai OBGYN Society for the lamp lighting of today's webinar. May we have the prayer, please?
ये खत्म
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you for that. Dr. Vaishali, would you take over?
Yeah, it's a great honor for me to welcome everyone for this POGS Cutting Edge webinars. And it's a great privilege for me to introduce our chief guest, none other than Dr. Nandita Palshetkar. And this name is synonymous with beauty and brilliance. And Madam, as you know, is the darling of the masses, entire India, whole of Foxy. Absolutely love and adore you, ma'am, for the person that you are. So kind, so generous, so warm-hearted, and so very friendly that you connect with everybody from the junior to the senior most people. And Dr. Meenu and I have been truly blessed to have worked with you when you were president Foxy, and the way you have inspired and motivated us, and you literally pulled us up. I remember at the release of my Foxy Focus, you called me on the dais, you made me stand next to you while the Foxy Focus was being released. I remember each and every gesture of kindness that you have shown towards us, and we truly love you, ma'am. Madam has been Foxy president, she's been president of VISA 2022, she has also been president IAG 2017, she's been president AMOX, president MOGS, and Foxy representative to FICO. Now she's a FIGO project head PPH, co-chair of REI committee CEFOC. Madam is now organizing chairperson AICOG 2025, which is absolutely going to be the most out of the world conference, and entire India is looking forward to it. Madam is a big name in IVF ART. She's been the pioneer in India. Oh, Madam, truly honored, and we are very happy you're with us today. So I request Madam to say a few words and give us your blessings.
Thank you, Vaishali. You've really overwhelmed me. Thank you for the love and affection. And I think I was lucky that I was there when all you youngsters were coming up. I can see a lot of my old friends. And Anahita, welcome. I think I'm happy to be part of the MOGS and the POGS webinar. You have a virtual background, so you're really jumping around, Anahita? Okay, so and I can see Meenu's been a friend for 20 years, and I've seen her dedication and her focus. I think it's hard. All the best in your endeavor. You're going for vice presidency. I think it's a culmination of the hard work that you've put in for Foxy. As a chairperson, I think you were also with me, and we really enjoyed that the tenure together. And of course, there's Charulata and Vaishali, who are the conveners of this program. So congratulations. I think it's fantastic. Madhura has been very diligent in bringing up people and getting everybody. And all my old friends, I think Neeraj, I'm happy to share the podium with you. And my dear friend Sanjay Patel, who is busy operating, I think. But Gautam, Gaurav, Preeti, they're all part of the MOGS family, and I've grown up with them. And Pratik, finally, I think Pratik has been my go-to person. He really worked very hard with me. And I think, Pratik, you're doing so well because you work with passion and dedication. Today, I would just like to say that in this webinar, I was very impressed because you have something for everybody. It's a miscellaneous, and it's, there's obstetrics, there's gynecology, there is, infertility, endoscopy. So I think that's really amazing. And something which all of us want to, like, if you have only one subject, it gets too much sometimes, I feel, when you have three, four talks on that. But mixed bag is sometimes welcome because all the scenario around in the webinars is single topic. So I think this is really a good welcome that we have different things so that people can, listen to different topics. And there are a lot of take-home points which we make. And I always believe that all these webinars, these CMEs which we conduct, actually result in better healthcare for the women we serve. And definitely each speaker takes a lot of effort in updating, giving you the latest and the pros and cons of each therapy and what they're talking about. So I think Foxy is one of the most vibrant societies that is there, with everybody so passionate and all go-getters. Everybody is doing so well. So it's really amazing to be associated with an association like this. And I just want to wish all the best to Meenu, and thank you, Pune OBGY Society, for inviting me here. And it's really a pleasure. Great job to see all my friends from MOGS over here. Anaita is one person who has led MOGS with, unwavering dedication. And she's really worked very hard for the whole year. So Anaita, it was a real pleasure to be with the MOGS seminar. Thank you. Thank you very much.
Thank you, Dr. Nandita. Your words mean a lot to us, and we actually hold on to each and every word that you speak because it has so many years of experience, so much wisdom, and so much love that is, so visible each and every time you speak, every time you meet. So thank you so much for that. And we now introduce our guests of honor for today. We are so happy to have Dr. Sanjay Patel, sir, teacher of teachers, and he has joined here in spite of his extremely busy schedule. I think I can see his laparoscopy glasses on his head, and he's, just, I think, stepped out of the OT to be with us, POGS and MOGS, as our guest of honor. Can we have Sir's CV slide, please?
Sanjay, good to see you.
Yeah, it is such a pleasure to see you, Sanjay. We have been together for so many conferences arranged by Meenu on laparoscopy and infertility. And Dr. Sanjay Patel has always been such a great support to POGS and to all of us. So, yeah, we all know him as the laparoscopy man who's not only been into complicated TLHs, but so much of work on endometriosis, which we all have witnessed. His laparoscopic tubal recanalizations have been so popular. And he's one of the pioneers of gynec endoscopic surgeries in India, first gynecologist in Asia to perform the laparoscopic Vadheim cystectomy. And I think adenoma resections, yeah, that was one surgery which we all dread a lot. But when Dr. Sanjay Patel does it, it looks so very simple. So he's the youngest and the only doctor in India whose center has been approved for training and research in gynec endoscopy. Good. Has performed more than 60,000 surgeries and has trained God knows how many doctors. We are all happy to say that, yes, we've learned a lot from Dr. Sanjay Patel, sir, ourselves. So thank you for being a part of our webinar. Thank you for honoring it as the guest of honor. And we would like to hear a few words from you. Over to you, Dr. Sanjay, sir.
Thank you, Charu, for the kind words. And thanks to you and Dr. Meenu to giving me this opportunity. Today, I'm extremely happy. The chief guest, very dear friend of the Nandita Palsepkar, even though Nirav Jadhav is dear friend, he is the chairperson of the sexual committee, and entire team of the POJs. I'm affiliated with so many years with the Pune. Vaisali is also Vaisali Kishore, Kundar, Manish Bachao. So many people I think I remember, and every time I get the warm welcome from the Pune. And today, thank you very much. Today, I'm one of the part of this prestigious webinar. Sorry, I am busy with one of the surgery, and she's suffering from the very small lady, a small girl, 9 years old, with the torsion of the ovary, and that's why I'm stuck with this surgery. Sorry for that.
Thank you, sir.
And I think a part of the particular, before this webinar, I tell you related to part of the sonography is the eye of the gynecologist. Without transvaginal sonography, even though it's next to impossible, do the OBGYN gynec practice. And second is the endoscopy. I think endoscopy has changed the scenario related to not only the part of the fertility aspect, but entire aspect of the particularly give the quality of life for the woman. And I think it's the really one of the two part, I think, in the last couple of years, I think it's the change the entire modality and change the science and change the scenario, future scenario of the gynecology. Charu, thank you again, Charu, and thank you, Minu. Nirav.
Hi, Sanjay bhai.
Yes, Minu.
Thank you, Sanjay bhai. Thank you for coming in between your surgical procedures. And I think Sanjay and I, we have been together, I don't know, like from childhood, I feel, because we
Yes.
have been together for so long. We were together.
The great memory, Minu, with you. I
Yes.
think one of the memory we at the Austria, at
Professor
Austria.
Kexter.
Yes.
We did our endometriosis training together over there. We were, there for 3 weeks. We did everything, paragliding, and I don't know what
20 years back.
Yes, yes.
You're very lucky that you got Sanjay on as a guest of honor and that he has come. He's such a busy man, but Sanjay, amazing stuff that you do, really.
Indeed. I remember when we went to Professor Keckstein, when he saw Sanjay's video on ureteric endometriosis, he said, "Why have you come here? What have you come here to learn?" So that was even then, and he was so young, Sanjay, at that time. Even then, Professor Keckstein said that, "Why have you come here? You are better than me. You are so good." So, and he is, of course, everybody knows he is amazing in his surgical plain surgeries. And and thank you so much for being here. For me and for everyone, POGS, MOGS, and especially for Nandita, I'm sure you are there for all of us. And thank you very much. And thank you, Nandita, for coming. And as Vaishali said, you are loved by masses. Everyone loves you. So, and you are so connectable. You're so approachable. When we were chairpersons at that time, also we could just pick up the phone. Sometimes I would hesitate to pick up the phone and talk to you, but you would pick up the phone and call. So that's a very, very positive thing that you have in you, and very rare thing that you have in you.
We learn from the Nandita. This all the quality of the life, the quality of the particular relationship with the other people. We learn from the Nandita.
Yes.
She's so humble. Yes, definitely. You telling this is the golden words for the everybody. How you, I think, behave with the life. This is very important. Rather than you are the great gynecologist or great surgeon. A part of that, I think, the good human being is the one of the most important part in the life. And Nandita, thank you very much, because your quality is pursued with every gynecologist. Yes.
Yes. Let's enjoy our lives, I think. Let's start with
So
the
this is another learning in webinars. We learn so much other than our curriculum also. So thank you, stalwarts, for being here. And now you take this opportunity to welcome our dear friend, Dr. Neeraj Jadhav, who's our second guest of honor for today. Dr. Neeraj appears highly sincere and sober, but you should see him on the dance floor, and he just rocks the dance floor. That is my first thought whenever I think of Dr. Neeraj. But coming over to formal introductions, he has been the chairperson of the Section Medicine Committee, FOXY 2020 to 2023. He's the winner of the Best Committee of Foxy Award 2023, has been the past Vice President of the Rajkot Menopause Society, West Zone Coordinator of the Adolescent Committee, Joint Secretary of Rajkot OBGYN Society, and he seems to have done so much work for Rajkot, for Foxy. He's the Organizing Secretary of the SOGOG 2014 conference. And indeed, he has won the prize of the Best Committee of Foxy during his tenure. So here we have a winner with us who's looking forward to doing much more in Foxy and for everybody. And I think we are really blessed to have him as our guest of honor today. So Dr. Neeraj, we would like to hear from you regarding our webinar and say a few words about the webinar. Over to you.
Thank you, Dr. Charulata, for your generous, kind words. First of all, it's a little bit surprised because when Dr. Meenu called me that we want you as a guest of honor, but frankly, I'm not that much used for such guest of honor. So thank you, Dr. Meenu ji, for inviting me here. And thanks to Pune Society for this series, cutting edge series on the different topics. Regards to Nandita Madam, such a lovely person, always smiling, and whenever we meet online or offline, it's such a pleasure to meet Nandita Madam. So regards, Madam, and regards to Sanjay Bhai, our legends from the Gujarat in the field of endoscopy. I can see Anita and Pratik. Hi, Anita and Pratik. So I can see the topics today are very much interesting topic like USG in gynec, very vast topic, but I think Dr. Meenu will deliver very concisely what is the important points and carry home messages in sonography in gynec. Then second topic is very much interesting because I like that topic very much, intrapartum care and the happy motherhood. And the third topic, that is vessel sealing in the endoscopy. So when I saw topic, I was searching for the respectful maternity care. So I thought, okay, let's see what is going on for the respectful maternity care as such. WHO also is recommending that we should now focus more on the respectful maternity care. So there was one meta-analysis which I come across in 2000. It was published in 2020, and it suggested that there are 49% ill treatment in form of non-consent, 25% reported verbal abuse, 23% threats. It was a threat, and 16% report of the physical abuse, and the 14% incidence of discrimination. So still, maybe in our private practice and the corporate hospital, we can't think of such old things, but in the government hospital as well as in the trust hospital, so many things will be going on. So we have to, whenever we have about the maternity care, we have to change so many things at the ground level as far as the respectful maternity care. And I'm really eager to learn that talk, which is the second topic. So congratulations, Meenu for this series, and I wish all the best for your future endeavor. You are going for the vice presidency this year, so I wish you will win with so much.
To the end of our inauguration, Dr. Meenu, you would want to say something?
No, thank you very much. And Dr. Anaita is here, and we are doing this webinar with MOGS. So would you like to say a few words before we start the webinar?
Thank you, Meenu. When Meenu called me about 3 or 4 weeks ago to say, would you like to join hands? I just jumped at the offer because every year I think MOGS has always looked to interact with Pune OBGYN Society. It's like a sister society for us. So every time any opportunity comes, we are always very happy to join with you. And I take this opportunity to congratulate you, Meenu, for doing a fabulous job. I also have the honor of introducing you, which I will in just a minute. But just to say that Charu, yourself, we are almost got a relationship like sisters. I think that's a wonderful relationship that we have cultivated with no jealousy, no envy, just putting all our resources together and working for the betterment of our societies and our women. I think this is something that other societies can also learn from Mumbai and Pune. So with that, I really do congratulate you, Minu, for taking this initiative. And of course, since COVID, we have always noticed that webinars are super, super successful. So this series also, Cutting Edge, is going to be fabulous. Thank you.
Thank you so much, Anaita.
Thank you, Anaita, madam. And with this, I think we can proceed with the first session. And it's a great honor for you, for me, ma'am, to introduce you. Dr. Anaita, you have taught me at KM Hospital. You've been a teacher, and we used to watch you operate and learn from you. So that way, we've been truly fortunate. And Madam, Dr. Anaita is the highly dynamic president of MOGS, and Madam has done huge, tremendous amount of work during the entire tenure. And Madam is surgically, she has very high expertise in all the topics, hysteroscopy and adenomyosis, menopause, and so on. And I myself have witnessed Madam's surgery and learned from Madam. She has published many papers in India, abroad, and she's member of many important medical associations. And she believes in promoting health awareness and lifestyle. And thank you once again, Madam, for joining with Pune OBGYN Society for this webinar.
Thank you, Vaishali. And I think we should now move to the first topic, which is our dear Minu Agarwal. So can I go ahead and introduce her? Not that she requires
We would
any...
also like to we would also like to invite Dr. Pratik Tambe, sir, along with you to chair the session.
Go ahead. Go ahead.
Vaishali, ma'am, if you could introduce, sir.
We've already had enough ceremony. Let's
Dr.
not stand
Pratik,
on any.
no, it is a great pleasure and honor for me to welcome you. Dr. Pratik has been a dear friend since many, many years, and especially for Dr. Minu and myself, when we were chairpersons during Nandita madam's tenure, Pratik was the person to go to. We would just, reach out to Pratik and he would help us and solve all our problems. So Pratik, we have such wonderful memories of working with you, and the way you have helped us out every single time. We are truly grateful to you. As you know, Dr. Pratik Tambe is ART consultant, gynec endoscopic surgeon, and he's trained in clinical embryology and ICSI at London, Singapore. He's member of ICOG, ICRM, MOGS, ISAR, MSR, and he's been past chairperson Foxy Endocrinology Committee 2017 to 19. And I think, Pratik, you hold the record of doing maximum number of CMAs and maximum number of activities any chairperson has done in Foxy till now. Is that right? And
thank you
he's
very
also
much for inviting me. It's lovely to be here among friends. I will not say distinguished colleagues, but I will say friends. And it's amazing that we've all grown together, walked together, and I look forward to seeing all of you becoming vice presidents one day. All the best to you, Dr. Minu.
Thank you, Pratik. Thank you so much.
I request Anaita madam to just introduce Dr. Minu.
Yeah, thank you. And now for the formal introduction. And I don't know, but I'm sure that everyone knows who Dr. Minu Agarwal is. She is currently the president of the Pune OBGYN Society and my counterpart. So we do have some programs together, including this one. She is elected as the Secretary General of the International Society of Gynecological Endoscopy. She was the Foxy Imaging Science Committee chairperson 2018 to 2021. She's Bachelor of Reproductive Endoscopic Surgery from the European Board, and she's conducted lots of workshops and training on endoscopy and ART in the UAE. She has over 12 publications, first author in 4 books, and she has been awarded as India's greatest leader by Asia One, Icons of Health by Times Group, and Foxy Champion of Champions. So here's to you, Minu. All the very best for your future endeavors. And please go ahead and let us hear you speak now.
Thank you, Dr. Anaita. Thank you so much for this kind introduction. And yes, MOGS and POGS do share a special bond. We are neighbors, we are sisters, we are both societies kind of, like sharing societies kind of thing. So it's always a pleasure, and it's always a great thing to be associated with MOGS in any, whether it is a webinar, whether it is a physical exchange conference. And MOGS has its own style, which we are in awe of. MOGS style, they are like style icons for us. So thank you very much. Thank you, Pratik, for always being there for me and for all of us. And thank you for joining as well. So I shall be talking on ultrasound in gynecology. And before I start, I also want to thank Dr. Neeraj Jadhav that he's here today as the guest of honor, along with Dr. Sanjay Patel and the chief guest, Dr. Nandita Palshedkar. So, good evening, everyone. About an hour ago, I came to know that we already have about 175 registrations. So now I don't know how many more have joined in already. So thank you for joining, everyone. And we'll try and give you, the clinical and the scientific knowledge that we all are always in quest. So ultrasound in gynecology. One thing, as an imaging science chairperson, my advocacy was that every or obstetrician should be able to ultrasound or a decent anti-scan. Also, to read a report, sometimes you send a patient for an obstetric ultrasound and the report comes, but it is not very, very clear what the sonologist means by whatever that he has mentioned in the report. So that was my advocacy. Patient is very comfortable when when she is in your clinic. You are also comfortable in doing a transvaginal sonography. Many a times we send the patient to a radiologist for a TVS, and most of the times they come back with a transabdominal report because they say no, the radiologist said that patient is not comfortable doing a TVS with him. So, and they don't make an effort to convince the patient. Time management is much better when we are doing our own ultrasounds. We can do damage control immediately. Patient comes on, say, day 8 of the cycle. She has a follicle sitting there 14 mm. I know that I have to give a HMG injection. She has a follicle sitting, say, 18, 19 millimeters with a good color Doppler flow. I know that I have to give her an HCG trigger rather than patient coming to us the next day and then we are taking a decision on it. How to prepare the vaginal probe, very important, a verbal consent, a female attendant for all the male gynecologists, privacy, be gentle, brief gynec history. When patient is coming for the first time, then we ask the patient to do a first ultrasound, abdominal ultrasound. So even if it is a partially full bladder, do an abdominal ultrasound, then ask the patient to empty the bladder and then do a transvaginal sonography. And subsequently, we can only follow it up with a transvaginal. Sometimes with a transvaginal, you may miss a big fibroid sitting somewhere, a pedunculated fibroid, so that those things can be missed if you don't put your hand on the abdomen and you don't do abdominal ultrasound. So this is what nowadays sometimes young fellows and residents, they just go ahead with the TVS without actually examining the patient. Wear a pair of gloves. No jelly. We don't use any jelly for infertility patients because it becomes, even for other reproductive age young patient, it becomes very messy. And suppose we have done a sonography with jelly and we tell them, okay, you must have intercourse tonight, this evening, because your follicle is about to rupture, and all that messing with the jelly sometimes makes it very uncomfortable. Also, jelly may prevent the sperms to ascend up. So we always use normal saline. So keep a 10 ml normal saline in the syringe. We just push normal saline. I think you can see my hands. Push it with one hand. The syringe is still inside. And with the probe, while the syringe is coming out, the probe goes in. So the normal saline act as a interface. Another important thing, especially when you're dealing with infertility patients, whether to use a condom or to use a probe cover. So ideally, we should always use a probe cover. But sometimes if you want to cut the cost or it is not available, we are working in a government sector, then even a condom can be used, but it should be nicely washed. Just take normal saline in a kidney tray, put the condom in that, and just rub it, that anti-spermicidal agents which is there, and then always put jelly inside and outside of the either the probe cover or the condom that we are using. So and the vaginal ultrasound has a higher frequency, very good resolution, but as I said, depth may not be as good. So that is why we should combine both abdominal and vaginal sonography for the first time when the patient is coming. So whenever we are doing an ultrasound, as a gynecological ultrasound, what is a normal pelvic ultrasound and how to diagnose fibroids, polyps, adenomyosis, endometriosis, hydrosalpinx, dermoid, how to do the scanning in infertility, how to look at the ovarian reserve. These are the few things that I will be covering up. So when we look at this is the normal uterus. So this is the size of the normal uterus and also the shape of the normal uterus. So we take the length from the fundus, from the highest point on the fundus till the cervix. So that because unless you find a focal fibroid or adenomyoma. So if it is a generalized size which is bigger than this size, then look for, I will tell you the points for the adenomyosis. Then look for when we take a coronal view, very, very important. You see here, these are the two tubal ostia. जैसे हमको हिस्ट्रोस्कोपी में ट्यूबल ऑस्टिया लैंडमार्क है, वैसे ही अल्ट्रासाउंड में ट्यूबल ऑस्टिया लैंडमार्क है. So once we see the tubal ostia, if this line is connecting the tubal ostia, we see here, and there is no, this is a normal uterus, right? This is the fundal myometrium, this is normal. Here you see these are the tubal ostia and there is myometrium between the tubal ostia. So this is a partial septate or a subseptate uterus. Over here we can see that this whole thing, these are the tubal ostia again, and this is where it is coming until the level of internal os. So this is a complete septum, and whenever we find a dip here, at the fundus here, you see myometrium, all this myometrium is straight here, but here you can see there is a dip in the myometrium. So this is a bicornuate. So very, very basic, and this is how we should diagnose. Then we look at the endometrium. So this is how the endometrium will look in the first few days, first, second, third, fourth. Thin endometrium, it could be homogeneous, it could sometimes also be triple line. Then we look at it in the proliferative phase. So day 7, day 8, up to day 13 or 14, you may find endometrium like this. You should also concentrate how the echogenicity of endometrium inside between these two lines. And there are some people who measure the endometrial thickness from out to the center, from center again to the out, and then they add it up. And then, of course, this is the secretory endometrium that we will see in the luteal phase. So suppose I don't know the LMP of the patient, I put in the probe and I find something like, either of the three, I should be able to tell that this probably is this day of the cycle for her. And then you can say, yes, I am pretty well accustomed to the ultrasound. So this should be your motto, that you put in a probe, you look at the ovary, look at the uterus, and you should be able to tell which day of the cycle she should be in as per the ultrasound. Sometimes we find thick endometrial echoes, you can see over here. So what we normally do is we keep an IUI catheter and we push little normal saline. into the just cross the internal os and push little normal saline. So you see over here. So this is how. So now very clear that this is a polyp. You put a color Doppler and you can see a single vessel supplying. Again, this single vessel supplying is important because even if you resect this polyp hysteroscopically, suppose you are cutting it off with scissors, the base, and if we don't coagulate the base, there is 40% chances that this polyp can come back. And your patients will come to you only, and after 4 months, she will say, Doc, you removed my polyp, and why has it come back? So these small precautions we must take when we are either doing the ultrasound and also at the time of the surgery. So this is how the size of the ovary, about 3.5 centimeters and about 2.5 centimeters, 2 centimeters wide. So if you look at your thumb, so this is the size of the ovary, a normal sized ovary. Again, very, very important to look at the size of the ovary. Smaller sized ovaries, lesser number of antral follicle count will guide you towards a poor ovarian reserve. Bigger sized ovaries, good number of follicles, may be good ovarian reserve, and sometimes they can also be PCO ovaries, which I will discuss. Then when we talk about PCO, now very, very clear guidelines are there by ASHRAE guidelines. So I get patients, 15-year-old girl, mother says usko PCOS hai. Why she has got PCOS? Because she went for an ultrasound and the radiologist said that she has got PCOS. Now, again, ASHRAE guidelines are very clear that PCOS or polycystic ovarian disease should not be diagnosed by ultrasound in girls which are less than 8 years post menarche. So suppose usko period start हुए 11 years of age में till the age of 19, we should not diagnose PCO on ultrasound. But we can definitely put her in a category of PCO if she has hyperandrogenism, if she has hirsutism, if she has irregular cycles. So all that can be taken into consideration, and we can then put her on treatment accordingly. So post 8 years, post menarche, then if we count the follicle numbers per ovary on transvaginal sonography, more than 20, and the ovarian volume more than 10 ml square. So this is how the follicles should be arranged in such a way that you have a thicker stroma. So that is again very, very important. Now this is a normal ovary. It is maybe a young 19-20-year-old girl. So this is multifollicular studied ovary. This is a PCO ovary. This is a PCO ovary. So we must be able to distinguish between this ovary and this ovary. I mean, I even get sometimes doctors coming with their daughters with a report like this, thinking that she has PCO, because you're worried about your daughter. Then you are not looking at the finer points of the ultrasound, which is absolutely fine. So we have to again counsel them, and we have to tell them that this is not a PCO ovary. Again, if we find number 1, ovarian smaller sized ovaries. Number 2, when we put the color Doppler, we find that the blood flow is not very good. And number 3, the antral follicle count is less, maybe less than 2, less than 3, less than 4, whatever. So lesser follicular count, definitely less than 4, 4, 3, 2, 1. So that will put the patient in a poor ovarian reserve. Then endometriomas, very, very easy to diagnose. They have low-level ground glass-like endometrial echoes. If they are unilocular or they are bilateral or unilateral, so that has to be, and very important, if she has endometriosis, endometriomas, and she also has pain while defecation, while intercourse, please also we must look at any evidence of rectovaginal nodule, because these patients may have rectovaginal endometriosis, which may be masked by our ultrasound picture. We just think, oh, she's got endometriosis, and we don't look at that point. So if she needs to go in for a surgery, then that has to be documented either by a good ultrasound or by a pelvic MRI. Dermoid, again, if dermoid means you take a bag, uske andar balls भर दो बस. and you take an image of that bag. So this is how a dermoid is. This is how the ultrasound picture will look. So anytime you find a picture like this, there's a round, you see 4, 5, 6 balls. So always be suspicious of a dermoid. Then adenomyosis. So whenever you find one wall thicker than the other wall, so it is adenomyosis unless proved otherwise. Also look at small echogenic areas in the myometrium and maybe small cystic spaces in the myometrium. And if you zoom the endomyometrial junction, you will find disruptions in the endomyometrial junction. So again, very, very important for counseling, both for abnormal uterine bleeding, pain, and also for infertility. Whenever we are looking at the ovary, suppose you can't find an ovary, so look at the iliac vessels. Medial to the iliac vessels, you will find the ovary. So, get tuned to looking at iliac vessels. It is not difficult at all. Iliac vessels and uterine arteries. I have not put a picture image of uterine. Uterine also is very easy to find. So when you put in a probe, you see the bladder. Between the bladder and uterus, there is a white line. And the end of the white line, you put the color Doppler and you will find uterines there. You take your probe on the right side or on the left side, just lateral to the ovaries, you will find the ilex. So you can put a color Doppler and see. Medial to the ilex is always ovary. So the normal fallopian tubes are not seen on ultrasound. So if we find any dilated structure between the ovary and the iliac vessels, it is a dilated fallopian tube unless proved otherwise. So it can be hydrosalpinx, it can be a biosalpinx, and that has to be noticed. Uterine fibroid, again, a very, very common findings on ultrasound. Sometimes you may have degenerative changes, sometimes you may have calcifications. Location of the fibroid is the most important thing in a fibroid, because we all understand only the fibroids which are submucosal or intramural with submucosal component, those fibroids are going to cause either abnormal uterine bleeding, pain, or early pregnancy losses or infertility. Generally, the intramural and especially the subserosal fibroid will not cause any problem unless they are very, very big in size. So at our center, and I think most of the centers in Pune, because we have Dr. Manoj Chinchwadkar critical care center, where he does a beautiful mapping of the fibroid. So if I get a report like this, I tell the patient, see, I'm going to remove this fibroid, I'm going to remove this, and these 1, 2, 3, 4, 5 need not be touched. So patient should not go 4 महीने के बाद कहीं और sonography करा के another doctor and comes back to you, doc, you didn't remove all my fibroids, because we did not counsel the patient with the proper mapping of the fibroid and discussed her why I am not leaving these fibroids behind and why I am removing the other fibroids. Isthmocele is another very, very common, not very common, but it is commonly seen on ultrasound. तो उसमें पेशेंट को क्या होगा, पोस्ट मेंस्ट्रुअल स्पॉटिंग, ब्लीडिंग, समटाइम्स शी मे आल्सो कम अप विद इनफर्टिलिटी, जैसे रमजान चल रहा है एंड दे कांट प्रे, दे कांट कीप फास्ट, सो इट इज वेरी अपसेटिंग फॉर द पेशेंट. सम पेशेंट वांट टू गो टू द टेंपल, दे कांट डू इट. सो पेशेंट कमिंग विद पोस्ट menstrual bleeding, spotting with previous history of 1 or 2 C-sections. Sometimes patient has come to you with some other problem. Okay, but she has a previous history of C-section. Always look for an isthmocele, because 50% may be asymptomatic, but your eyes will get tuned to looking at isthmocele. So when you actually have a patient with symptoms, you can pick it up very fast. So it is, and you can again, as I said, take a normal saline, push it in the uterine cavity. You can see here nicely isthmocele here. See, this is the isthmocele over here. This is, or you can do the ultrasound in the menstrual during her menses. So then also you can see this beautifully isthmosed. And then I will not go here, and then it can be managed hysteroscopically or laparoscopically, depending on add when you see a dominant follicle for IUI. For IVF, we started at this stage when we on day 1, day 2, or day 3, when you have smaller antral follicles. Also, if you want to add estrogen in a thin endometrium for IUI, it should be added only after you see a dominant follicle, because then the estrogen will not cause a negative feedback. This follicle is an independent follicle which will keep growing in spite of increasing estrogen in the body. So this is how the follicle will grow 1 to 2 millimeters per day. Very important also to check for LH surge. So when we are doing ultrasound for infertility and if we find good follicular flow, very good perifollicular flow, we find a cumulus here, we find a small bit changes of secretory endometrium coming here. What does it tell us? It tells us that she has got an LH surge. Now, if she has got an LH surge, should I be giving her SCG, wait for 36 hours and then do IUI? No, because she will have ovulated, because she has got an endogenous LH surge. So if you do serum LH values, you do urine LH test, it is positive, then you should do IUI either today or tomorrow and not wait for 36 hours. With SCG will not cause any harm, but it will not delay the ovulation for us. So that will only happen if spontaneous LH surge has not come, then SCG will cause as a surrogate marker, it will cause an LH surge. So that is again important for us to understand. So this is how the corpus luteum will look on day 21 and the endometrium will look on day 21. Very important also, as I said, to see how is the grading of the endometrium. This is a grade A, grade B, and grade C, and also put the color Doppler when we are doing our own ultrasound to see grade zone 4, zone 3. These zone 2 and zone 1 probably may not give us a pregnancy. Even if you're lucky to get a pregnancy with this type of an endometrium is good, but the blood flow is not good. These pregnancies are very likely, very high incidence of early pregnancy loss. So that also should be kept in mind before we start celebrating that we got a pregnancy. So this is how we measured any follicle, always in 2 diameters, and then second one bisecting the first one, first in the longest diameter, and then you take an average of the 2. So very, very important. We must have a sound knowledge of ultrasound or OBGYNs. So once we suspect pelvic pathology. Now, again, ASHRAE guidelines are very clear that you do 2D ultrasound as per ASHRAE guidelines. Only in suspected pelvic pathology, patient goes for a 3D ultrasound. So 3D ultrasound as per ASHRAE is not to be taken as a standard a method of standard care for patients. So 2D ultrasound is good enough. Any troubleshooting and of course fertility management is very good, very manageable if you are doing your own sonography. So you know how to do a damage control, what to do when. So all that is very, very important. So thank you very much. And thank you for everyone's blessings for me. And thanks a lot. Thank you very much.
Thank you, Dr. Meenu, for taking us through that journey of how to start doing the scan, if you use jelly or not, and then the nuances of transvaginal ultrasound, the different characteristics of the polycystic ovary, the endometrial tracking, follicular tracking, all the important areas where it's important for a general gynecologist also to know. You rightly avoided the more complicated issues of oocyte retrieval and embryo transfer because that would be overkill for the audience. But it's wonderful to listen to you. You've been imaging science chairperson, and I think you conveyed the right amount of information that was required for the audience in the perfect amount of time. Thank you very much for this wonderful talk, and I wish you all the very best for it.
Thank you. Thank you, Pratik. Thank you.
Thank you, esteemed chairpersons, Dr. Anaita and Dr. Pratik. Dr. Meenu, a fantastic talk as always, and every time we learn more and more things from you. So congratulations and all the best to you. So we move on to the next session, and the next session is talked by Dr. Preeti Vyas, and to chair the session, I would request the chairpersons, Dr. Ganpat Sawant and Dr. Gautam Sonawne. Dr. Ganpat Sawant, is he here? Has Dr. Ganpat?
Yes, he's joined. Yes, he's joined.
Yeah, actually, I am very much here. I am listening to Dr. Minu also,
Okay.
and I am hearing you also.
Yeah. So, Dr. Ganpat, it's a great honor. And it's a lot of happiness for me to introduce you, you being a personal friend since more than 35 years now. And Dr. Ganpat is a very well-known laparoscopic surgeon, senior gynecologist. He has been former HOD and Professor D.Y. Patil Medical College, Director Noble Hospital, Noble Plus Hospital, Ghatkopar, ex-president, Ghatkopar Medical Association, President-elect IMA NEBS branch, Mumbai, MOGS member, senior committee member, MOGS best committee member prize is won twice. And he has passed his UG and PG from GS Medical College. And while doing his PG, he has influenced many of us, including me, to take up the subject of gynecology. So a very warm welcome from Pune Obstetric Gynec Society to Dr. Ganpat.
Thank you very much.
Madhura, will you introduce the next chairperson?
Yes, ma'am. Thank you. I would also like to invite Dr. Gautam Sonawne to chair this session along with Ganpat sir. So Dr. Gautam Sonawne, he's an endoscopic surgeon and an infertility specialist from Mumbai. He's a managing committee member of MOGS. He's the founder director of Uma Hospital, and he also visits a lot of other hospitals in Mumbai. He's a very active member of many organizations like ISAR, IAGE, IMA, FPI Mumbai, and he runs a charitable trust called GS Medical Foundation, which works for the upliftment of marginalized women and children from lower socioeconomic status. Thank you so much, sir, for being here.
Thank you, madam, for kind introduction. Now we'll move on to our another session 2. Our speaker will be Dr. Preeti Vyas, madam. The session will be intrapartum care for joyful motherhood. Before we start the session, I would like to thank Dr. Minu Agrawal madam, Dr. Vaishali Chavan madam, Dr. Charudata, and Dr. Anahita Chavan madam for inviting me as a chairperson for this session. Our speakers for this session are Dr. Preeti Vyas madam. Dr. Preeti Vyas is consulting gynecologist practicing in Andheri East. She is the leading gynecologist in Andheri West. And madam is managing committee member of MOGS, Medical Council of India. Madam is member of FOXY, and she is practicing at Sangeeta Maternity Surgical Hospital and Diagnostic Center. Welcome, Dr. Preeti Vyas madam, for this session.
Thank you. Thank you so much, Gautam. First of all, I'd like to thank POGS and MOGS for making me a part of this. I think association with POGS has always been something that is fun. We started long back when we had the joint conference of POGS, MOGS at Lonavala, Khandala, Dukes, and it was really fun. And after that, I think we've made it a tradition to be with each other all the time. And then we had the one at Dukes. Then we had the one, I think, last year at Lonavala again. So let's continue the tradition. Can I start the presentation? I'll share my screen. Is this visible?
Yeah. Yes.
So what I'm going to talk today is about intrapartum care. Of course, this is a very, very vast topic and it's difficult to cover it in just a matter of 20 minutes. But what I'm going to talk about today is something different, something which is about how to have this concept of intrapartum care, which is protocol based. All of us want to not wake up in the middle of the night. We want our obstetrics to be taken care of in the day only. And this was way back where Dr. Sirish Daftari sir started this protocol, where he would have 90% of his deliveries happening in the day. And we had discussed this a number of times, with sir, and he had taught us that, you know what, Preeti, I have never missed a day at Wadia, and I've never missed my sleep at night, and I've always managed to still have vaginal deliveries. And this is what he would do. He would provide pain relief, which was optimum. His patients would always be so happy with him. Adequate uterine contractions. The contractions have to be strong enough for the baby to want to come out. It's an active management of labor, and obviously very, very strict clinical monitoring of all labor events. And he's the one who really used a lot of partogram. In fact, at his hospital, we still use a lot of partogram for all deliveries. So the reason why all these are important is because interventions such as epidurals, keeping the patient NBM for too long, not giving them liquids, not giving them food at all, giving them in a supine position, all these glands are probably increasing the rate of cesarean. And I think we all know we are all struggling with increasing rates of cesarean section all over the world now. Forget India, I mean everywhere, even abroad, they are struggling with that. And WHO says that good 10 to 15% of cesareans, even in USA, have been found to be unnecessary. Now, who decides whether this was necessary, unnecessary? So what decides is when we start documenting things, and that's where this intrapartum protocol comes into play. So when we say about active management, the package basically means that we need to first thing, educate our patient. The patient needs to be wanting a normal delivery. She needs to be educated of what to expect during labor, pre-labor, post-labor, what all pains would be there, what all options of pain which are there. There should be a strict criteria to diagnose that, yes, this patient is in labor and not in the latent phase. She's not in the pre-labor phase where unnecessarily you'll end up admitting the patient, and then, you know, the anxiety builds up from both the patient, the obstetrician, as well as the relatives. Routine 2-hourly vaginal examinations, or even less frequently as and when, depending upon the patient's condition. Amniotomy, make sure that oxytocin, if required, is given, and that too at this thing, and try and give one-to-one support to the person who's in labor. And this is how the partogram or the chart would look. And that's what we need to try and follow. So it was a concept which was actually started by the Irish school. Okay, it basically helped where the labor was shorter, obstetric outcome was better, cesarean rates were lesser, and it was basically an active management where you are trying to reduce the number of cesareans, but you're also trying to improve the outcomes by reducing infection, preventing exhaustion and dehydration in the mother, preventing ketosis in the mother, the disillusion that happens in the mother because of the electrolyte imbalance, because she was kept NBM for so long, and obviously the fetal distress is lesser because basically the labor was much shorter. So this was the original partogram that was used. This was the original partogram which was used, where there was a normogram, an alert, and an action line. Of course, now what we have is the WHO protocol partogram. Now what this has is a lot of additional things. As you can see, the time and the date of rupture of membrane, the duration of labor is pointed, the facility, clinic's name is mentioned. There is the chart for fetal heart rate monitoring. There is also space for mentioning the Liker, whether it's clear or meconium, whether there is molding, grade 1, 2, 3, we can mention the dilatation, the descent of the fetal head. What are the contractions? Was oxytocin given? If so, what was the drip rate for the oxytocin? What drugs, what IV fluids were added at this stage? Monitor the vitals of the mother, including her urine, albumin, as well as protein and ketones, okay, in order to figure out if the patient is going into exhaustion or dehydration. Now, this was a very nice comprehensive chart, and this is what we all need to probably start using it. It has been available for donkey's years, but not too many of us are used to using it. So what I'm going to talk about today is something about intrapartum care, which also includes how to use the partogram. Now, patient selection for an active management is most important. First thing, the patient has to be a low-risk patient, can be a primary or a multi with singleton pregnancy, where there is spontaneous onset of labor with a vertex presentation. She should be full-term between 37 to 41 weeks. On admission, an NST has to be done, has to be good reactive, and should already be 3 to 4 centimeters dilated with more than 50% effacement. These criteria are very necessary and strong. The presence of an anesthetist and a neonatologist must be confirmed, consent must be taken of the patient that yes, we are asking you to remain in active phase of labor. Definitely rule out any high-risk condition. So as I mentioned, it has to be a low-risk patient. High risk such as diabetes, preeclampsia, oligohydramnios, things where you think that there may be a CPD or there is a too large a baby or too small a baby. All of those have to be ruled out. The medications which have to be given is to be given only when the patient is in active phase of labor. So what is active phase? She should be minimum 3 centimeters dilated. Contractions have to be at least 3 in every 10 minutes, lasting for 35 to 45 seconds. The fetal head should be engaged. There should be no clinical suspicion of CPD. May not have show at all. A combination of drug is what is used. Now, this combination basically helps us to give analgesia to the patient. So there is painkillers which are given, and in addition, an antispasmodic. The combination of these two help not only in relieving pain to the patient, but also help in faster dilatation of the cervix. So the advantage is the synergism that we are trying to work on. And the advantage of this is that not only would it hasten labor, oxytocin to the rib. So 2 or 2.5 units is also enough for a multigravida. For a primary, we can put 5 units only if the contractions are not strong enough. Primiprost, of course, nowadays is not available, but we used to use them a lot. These patients, once they are 3 to 4 centimeters dilated, can be given a cocktail. A cocktail would be of Fortwin and diazepam. These two are both diluted with a 10 ml of diluent. Usually just 1/5 of the drug. So hardly 6 milligram of Fortwin or pentoxazoline and hardly 2 milligram of diazepam is required. A lot of times we get away with a little lesser dose also. And while this is happening and while this is being given, we can continue to chart the maternal and the fetal condition, continue to assess the progress of labor, see the dilatation, see the descent of the fetal head, make sure that there are no negatives happening, make sure the alert, the action line, all of them are being followed. When she's around 7 to 8 centimeters dilated, that's the time when you give ketamine. Now, this is the trick. The patient cannot be given ketamine too early, but should not be given very close to delivery. When it is given at around 7-8 centimeters, it basically causes analgesia, and it also causes a little bit of dissociation in the patient's mind. So this actually helps them to remain in a level of amnesia of the painful event that happened just at the time of this thing. And it is given at a time where it is not going to harbor their bearing down, because usually between 7 centimeters to a full dilatation is the time where the pain factors are maximum. So giving ketamine, a little small dose of it, works wonders in these patients. We know that there are lots of ways, to manage pain in a patient who's in active labor: walking, movement, giving them a rub, doing water baths. All of these are talked about. Of course, it depends a lot on what the mother chooses, but sometimes we need to talk to the patient that, yes, if you cannot take epidural for whatever reason, I mean, it's a proven analgesia, when we give epidural anesthesia. But there are a lot of times when either the anesthetist is not available, or the patient can't afford an epidural, or is not willing to take an injection. They have a lot of times this thing in the mind that, oh my God, I don't want to take an injection in my back. So then, but you still need to give them pain relief. You can't tell them, oh, you refused an epidural, now bear the pain. So there has to be something beyond that we need to be able to offer our patients. So when epidural analgesia cannot be given, we can either give them this, or we can even give them tramadol, which is a non-opioid analgesia, mixed with antispasmodics such as a trotaverine or a hyoscine or a valethamide, that is your epidocin that we use. Ketamine, a dissociative anesthetic, gaining popularity because it gives fantastic pain relief as a good patient satisfaction. Of course, you need to have your anesthetist stand by there. So what is the clinical evidence of this intrapartum protocol that we have? As you can see here, this is a trial that was done where, just 1 minute. So this was a trial that was done where the study group compared the ones which were assigned the intrapartum protocol to the controls. All of them were primary gravidas. 200 patients were taken on either side. And you can see here very clearly. What you can see is between the programmed labor and the control group, there was definitely a reduction in the active phase time. The dilatation was much more rapid. In fact, it was almost double that what is seen in the control group. The duration of second stage of labor was reduced to literally half. Even the mean duration of the labor or the blood loss, which was in the third stage, was less. So the duration of blood loss, the duration of third stage was lesser, the amount of blood loss was also lesser in these patients. So when you can compare the thing, the rate of cervical dilatation that was compared, it was found that in the case versus the control, the dilatation was 1.7 centimeters per hour as compared to just 1.23 centimeters an hour. When you see the duration of labor in the second stage, the active phase, or the third stage, all three, you can see that there was a good difference. 3.5 hours as compared to almost 5 hours, 27 minutes as compared to 34 minutes. Third stage, of course, remained almost the same for both. When you look at the pain relief score, it was fantastic. The pain relief was definitely comparable. When you compared this, it was 78 as compared to 22%. And what about the complications or the side effects? There were mild complications or side effects. I wouldn't call them complication, but the adverse reaction in the form of a little bit of nausea, vomiting, dryness of mouth, or a little bit of tachycardia, which you do land up seeing in patients of the case group as compared to control. But these are all mild, they're transient. Most of it disappears in a period of 2 to 6 hours. So as we can see, the rate of cervical dilatation was faster. The total duration of active phase is lesser. Second stage is lesser. Blood loss is lesser. Both the groups showed that majority delivered vaginally. So there was no difference much in the vaginal delivery in either group. However, the patient was definitely more comfortable here, where there was significant pain relief. Side effects which were mild disappeared in a very short time, and there was no significant fetal or neonatal complications. This was a funnel plot comparison that was done of an antispasmodic versus a control. And this is what was found, that they definitely reduced the duration of first stage of labor by the average of 74 minutes. Now that's fantastic. If you can manage to reduce the duration of labor by a good 1.5 to 2 hours, it would reduce the anxiety, the pain, the exhaustion of both the obstetrician as well as the patient. And this is how the comparison was, where the duration of first stage was reduced by 74 minutes, second stage 2.68 lower, third stage 0.06 lower. Your total duration was a good 85.51 lower. This was a comparison that was done between the nulliparous and the multiparous women, where they also found that as compared to not giving anything, there was a significant change, especially in the primates, where there was shortening of the second stage of labor. And what about the side effects? Again, the side effects, when you see statistically, they were not very significant. Yes, you do see a little bit of more tachycardia, but dryness of mouth was always there with these patients. Some of them do land up feeling a little flushing sensation. But these are all mild side effects, okay, irrespective. This was one more study that was done to compare how the age of the patient would be. And it was found that whatever the age of the patient, whether it is at the 18 to 20-year-old, 25 to 30 or 35-year-old, there was not difference in the adverse reactions that you could see with hyoscine or Valithemat. Hyoscine is the Buscopan in the common this thing, and Valithemat is the Epidocin that we all have used. And again, there was not much significance in the differences. Now, what about Drotaverine? Drotaverine is again another drug that we use all commonly. Commonly the combination that we use is Tramadol with Drotaverine combination is just given in the third at 3 to 6 centimeters dilatation as compared to Epidocin and Buscopan. So when you look at Valithemat, that is Epidocin group, they did have more of tachycardia, more of dryness of mouth, and a little bit of incidence of vertigo. When you look at the Drotaverine group, they usually used to complain of headaches. There was a little increase in the incidence of cervical tear as compared to this. Of course, these were very small numbers. They were in the study group of 100, 150, 200. Even in the Cochrane database that we looked up, it was like a mixture of a lot of 13 studies that were published, but it was all small studies. So we probably need to do more publications, as we all are using it, but we are not really documenting the same and publishing the thing, because till we don't publish, this will not become a protocol. Now, what I need to definitely stress on is how to read a partogram, because when you are doing any intrapartum monitoring and intrapartum protocols you're using, or even otherwise, even if we decide not to use, I think what we need to do is start using the partogram more often, because the integral part of the intrapartum protocol is partogram. So I've taken a few examples here. Now let's look at this one. This is where the crosses are the cervical dilatation. The zeros marked are of the descent of the fetal head. Now, this is a patient where she's got a dilatation of hardly 1 centimeter, which progressed to 2 centimeters at the end of 4 hours. And another 4 hours later, she was still there. What would this mean? This would basically mean that she's still in the latent phase. She never went into the active phase, and it is a prolonged latent phase. So this patient as yet is not in active labor and doesn't require active management. However, you can also see that there is a nice broad dark line that has been drawn here. I hope you all can appreciate that. This dark line has been basically a heavy line drawn on the partogram at the end of 8 hours of the latent phase for you to realize that either there is a prolonged latent phase and you need to figure out what's happening. Is she really getting contractions? Or do we need to shift her, or do you need to reassess the situation? Because latent phase is when the dilatation is still less than 3 centimeters, and it can vary from 20 hours in a primary to more than 14 hours in a multi. Let's look at this. This is where the patient came with 4 centimeters dilated. At the end of 4 hours, she was still the same dilatation, same level of station of the fetal head. At the end of another 4 hours, the dilatation had progressed to 6 centimeters. But here, as you can see at the top of the partogram, the LICO was still clear. Here, the membranes were intact and it's written as I. Now, at the end of another 4 hours, the dilatation had stopped progressing. Yes, the station had managed to come down, but she landed up having meconium. So this basically comes where there was an alert line which was crossed the first PV, but an action line was crossed here. And then there was no progress happening here, which was like a prolonged active phase. This is where a decision was taken and the baby had to be delivered because the cervical dilatation stopped. At the same time, the descent, the fetal heart rate, the LICO, the molding, all have to be considered. Let's look at this. This is a chart where the dilatation was progressing well here. First 4 hours started. However, after this, there was an arrest. The patient did not dilate. The descent of head never happened. And here you can see there was molding of the grade 3+. There was fetal heart decelerating down. And there is an M written which says there was meconium. So this became a way to document. It became a way for you to prove. Now with the way the medical practice is going to be, where every action that you take is going to be questionable, just writing on paper will not help till we start documenting it like this, that this is how we were monitoring our patient and it was progressing like this. And this is the reason why a decision had to be taken and a cesarean had to be done, where a baby, which was 4.6 kg, was born. If I'm able to document this, this is how it will save me even from legal issues later on in life. So this became a secondary arrest of dilatation with a fetal distress with meconium. This may be because of a mid-cavity outlet because the baby was big. Now let's look at this last case. This is where the patient was dilated at 3. She progressed to 6 centimeters, progressed to 7 centimeters, even went up to full dilatation. But what happened to the fetal head? The fetal head came to level 3 and it remained there. It never progressed beyond that. Even after full dilatation, she did not progress and the head never came down. So this is like a secondary arrest of descent of the fetal head. This is a way for us to start managing and charting the partograms down. So what I tried to talk today was on the concept, which rested on our 3 pillars. Make sure that you give adequate pain relief to the patient with analgesics and antispasmodics. Make sure there is an active management of labor to have the best outcome for the mother, and maintain a partogram. What is the advantages? Why should we even do this? Because 1, the pain relief is definitely better. Shorter labors happen. Significant amnesia happens of the painful events of labor because of the ketamine effect. Average blood loss is lesser. Duration of all 3 stages definitely is lesser. obstetric management becomes simplified. This can be actually put as a planned delivery. Patient can be induced in the morning. By afternoon, she's already on the drips. By late evening or night, usually these patients end up delivering. The operated delivery incidence is lesser, and neonatal mobility is, of course, variable. Thank you.
Okay, so Preeti, that was really a nice summary of the labor and how it was managed by one of our senior members, Dr. Sirish Daftari sir, is to manage that. It was based on a lot of things, as you said, giving amnesia to the patient, giving adequate pain relief to the patient. But if I'm allowed to say certain things, first of all, though it's an intrapartum, it is a joyous journey, it's really stressful to the OBGYNs. Till the time the patient delivers and few hours are gone, we are under pressure and we're under stress. I like the way you stress about the active management of labor. Yes, all of us should manage the labor with the help of partogram. And if you remember the Manyata, recognized hospitals, even staff is being told to how to monitor and draw the partogram. I have a hospital which is recognized by Manyata, and believe me, my staff has become expert good, and they themselves can monitor the patient properly. What I liked about this WHO partogram is everywhere it is mentioned there, where is the liquor, is meconium, where the liquor is clear, what was the strength of the uterine contraction, and they put a blocks if there's a good contraction, or only lines if they are there. You state certain points, something like consent for being in the second stage of labor, which, yes, we nowadays it's a time to take consent for the patient, whether she wants to be in second stage of labor and she's willing for this analgesia and anesthesia point of time. Long time I'm myself thinking as I'm becoming senior, how to monitor the pitocin. Though we say it's 16 drops, 20 drops, 40 drops, 30 drops, believe me, it's one of the difficult drop rates to manage, because as the patient movement change, the hand position change, the drip rate changes. True. So I think worthwhile using the infusion pumps to monitor this, which will have a really very well monitoring with respect to this. And we should talk more about the infusion pumps about this. Coming to the about those drips, I really I do not know whether sir uses all these things at present, like diazepam, ketamine, because this is like a hypnosis, patient developing amnesia, patient looks drowsy. But I think the critical or other side of it is, if the post-delivery the patient looks drowsy or the patient is not looking that alert, we are sometimes under pressure. What is something has gone wrong with it?
So in this, how sir used to give is that he would give it only between 3 to 6 centimeters. And literally the patient would only feel a little at peace. The patient would not be so drowsy that they get knocked off. They would only feel a little at peace where they are still quite otherwise active. They're even moving around. But there is this thing, that they want to just relax and sleep it off for some time. But they are quite awake otherwise. And this is only, and literally, I mean, the dose that was given is well titrated, where very little dose is given. So it is not given by the obstetrician. The anesthetist is kept. No. So that's one thing I mentioned right from beginning. It has to be with the anesthetist with you. You don't want the obstetrician to start giving ketamine and all. No. That's absolutely not.
That's a very strong message you gave, because anesthetist should be there.
Has to be there.
The one who can titrate the dose, because the ketamine at a different doses has a different action.
No. It cannot be given by the obstetrician. Has to be with the anesthetist sitting there in your cabin. Only then you can do that. Otherwise, no.
All right. So, in fact, at the end, as closing statement, I can just say labor is a labor to the obstetricians, but without us, who's going to manage this thing? It's of course our job. It's one of the most skillful job, which I think we only can do it. And well, good presentation. Thank you very much, Minu madam and Vaishali. Nice to see you. And yes, Madhura madam to chase us from morning till evening and giving these links and reminding again and again. But that was
part of the presentation. I in fact wanted to include a lot of it about the active management in second stage and third stage. It is becoming too long for this audience. I said, okay, we try and cut it down to this, and then maybe at a later
no,
date.
perfectly all right, Preeti,
Was
because of
perfect.
something. Otherwise, it's very difficult. So thank you very much, POJS and MOJS for involving us. And great, I enjoyed this talk after a long time. And thank you to see all beautiful faces on the screen. Thank you. Bye.
Thank you.
Thank you. Thank you.
Thank you. Thank you,
Thank you,
Sonone.
sir.
Yes, sir. Thank
Yeah.
you.
Thank you.
Thank you, Dr. Preeti. That was a fantastic talk. And you gave us such clear messages. The delegates who have logged in are going to benefit hugely. And really enjoyed your talk. And enjoyed Dr. Ganpat's comments very much. And Dr. Sonone, thank you for being here. All your insight, Dr. Ganpat, and your personal experience and your you've been a teacher, so all your comments have been really very good. Thank you for this. And so we move on to the next session. Dr. Minu, can we move on to the next session?
Yes, please. Yes, Vaishali. Thank
Yeah.
you.
So to chair, we have a next session speaker already here, Dr. Gaurav. And to chair this session, I would like to request the two chairpersons, Dr. Sudha Tandon and Dr. Nilesh Balkavde. Has Madam joined? Yeah. Madam is little unwell, Dr. Sudha Tandon. But Madam, thank you for joining with us today for this webinar with POJS, and it's an honor to introduce Madam. Madam is treasurer of IAG. She's been secretary IAG 24-25 now. MOGS and ISAR committee members, organizing chairperson of MOGS IAG Endo-ART conference workshop, Foxy chairperson, section 2017-19. And she's also been at AICOG January 2002, winner for best presentation of fertility enhancing hysteroscopic procedure. We know Madam as an expert laparoscopic surgeon, a big name in endoscopy, but we also know Madam to be a fantastic singer, and we have all enjoyed her multiple talents. And we have also seen her lovely daughters following Madam's footsteps. So, Madam, please welcome. Also, I would like to welcome Dr. Nilesh Balkavde, our very own young, dynamic POJS member. And we are truly proud of all the achievements and all the great work that Nilesh is doing as chairperson of Imaging, Foxy chairperson of Imaging Committee. And he's also a very successful ART consultant and a laparoscopic surgeon. And right now he is the joint secretary with Dr. Kiran Kurtakoti at AMOX. And his quiz, which he conducts at various platforms, are a huge hit. He also promotes youngsters and he's a great mentor for the youngsters, though he himself is very young. And he was also faculty for 5 years at D.Y. Patil Medical College. And he has been invited on various platforms to give a presentation nationally and internationally. So Sudha ma'am and Dr. Nilesh, I request you to start with the session.
Dr. Sudha, I think she has a bad throat. She's put in a message, so we'll ask Nilesh to take it forward. Thank you for coming on this webinar, Sudha. Thank you very much. Really appreciate.
Thank you so much. At the outset, I would like to thank Vaishali Madam for all those kind words. She's always been kind to me since my inception in POGS, and I'm happy to be a part of this POGS activity. And Madam is doing so wonderful work, Meenu Madam, with the cutting edge webinar series with all connecting all the societies all across India. So I know the content is also really good. So of all the sessions. So thank you for inviting me as a part of this webinar today. This session to chair is from our esteemed speaker, Dr. Gaurav. We all know him. He's a good friend of mine. We met in AICOG. So he's going to speak about various electrocoagulation or vessel sealing devices in the use of in laparoscopy. Every one of us started with the basics of bipolar, but we know we have an array of instruments available right now, and therefore a knowledge of that is very much required. Can we have Dr. Gaurav's CV, please, so that I can go through that? Yeah. So Dr. Gaurav Desai, as we all know, is a consultant gynecologist and pelvic surgeon in the city of Mumbai. He practices at Hinduja Healthcare. He's an assistant professor at KEM Hospital. He's a MOGS managing committee member. He has also received the IAG Future Award. And he is also the joint assistant secretary of the Journal of OBGYN of India. Much more to his credit. This is just a short CV. So I welcome Dr. Gaurav with all my heart and request him to take the discussion ahead. Thank you.
Yeah, thank you, sir. At the outset, I'd like to thank the Pune OBGYN Society and the MOGS for inviting me to give this short talk, especially Meenu madam, Vaishali ma'am, and Madhura for inviting me. Thank you so much. I've had a long association with Pune. At one time, as a child, I had even had a house over there, and we are members of the Pune Club. So we've had a long association. Can you all see my screen?
Yes, just make it full screen.
Yeah. Is that okay?
Yes.
Okay. So the topic that is given to me is quite a relevant topic in today's day and age. This is on vessel sealing technologies. As most of us have learned endoscopy, we've learned it using the simple unipolar and bipolar energy sources. And these were fairly standard, and the way they used to carry out their actions was quite easy to understand, and this is sort of written in each textbook. But with newer vessel sealing devices that are coming in, I think endoscopic surgeons and even those who don't practice endoscopy, because this technology is also available in open surgery, have to update their knowledge on all these devices. So at the outset, I'd like to say that I don't have any disclosures. What exactly is vessel sealing technology? I think let's start with that. So this vessel sealing technology is basically an electrosurgical technology that combines pressure and energy to create a vessel seal. Now, most of us are, of course, used to cutting and coagulation, but in these cases, the pressure and the electrosurgical or any energy, whether it is electrosurgical or ultrasonic, creates that seal on the vessel. Now, there are certain requirements of this vessel sealing technology or any instrument to be a vessel sealer. So first of all, the seal actually has to have a greater strength than other energy-based devices. I mean, that's the whole point of using a vessel sealer instead of, say, a bipolar device. Now, it has to have reduced sticking and reduced jarring. That's the whole objective in endoscopic surgery. Has to have minimal thermal spread. In fact, this is common to almost any energy devices. You don't want that energy to be transferred into neighboring tissues, and has to, of course, be reliable, has to have a consistent performance, and has to have a permanent vessel seal or permanent vessel wall fusion. It shouldn't be that you seal the vessel and after some time you have to seal it again. Finally, the seal strength should be comparable to existing mechanical based techniques. Now, what are the seal characteristics? So the seal characteristics, first of all, if you look at this picture, there is a characteristic sealing zone. So this is the zone that is sealed between the two vessel parts. So it has to have a distinctive seal zone. It has to be permanent, as I mentioned before, not temporary. It should not rely on a proximal thrombus. For example, it should not be that there is a proximal thrombus and after some time the thrombus goes away, so the vessel seal gives way. There has to be collagen remodeling and a plastic feel to that seal tissue. And of course, as this picture shows, there should be an absolutely fused intimal vessel wall. Now, of course, we have a number of devices available, I think, including lasers, but I will stick to the ones that are commonly in practice today. So the devices with adaptive tissue technology, or ATT, are ultrasonic devices. There are N-Seal, Vessel Sealer, there's LigaSure, Thunderbeat, and of course those that are available in the robotic surgical system. Now, adaptive tissue technology can be either tissue impedance or temperature based. So it could be due to the impedance, or that is sort of the resistance or the feel of that tissue, or can be based on what the temperature of the tissue is. It has to be based on the characteristic of tissue in the jaws of the instrument, and is usually computer controls of that instrument. And this electrical transfer is done in a pulse-based manner. As I mentioned, that this basic tissue or temperature-based system continuously adjusts the temperature and voltage generator. Now, this is just a sort of a cheat chart which I have. So where you have various devices and what they are based on. So for instance, the harmonic devices is based on ultrasound or ultrasonic and doesn't have a blade. Whereas the LigaSure or N-Seal has a bipolar base and a blade to cut. Whereas the Thunderbeat has a bipolar with the ultrasound and the blade. Now, what are the requirements of a vessel sealer? There is, of course, a bipolar generator as well as the instruments. The generator has to have a low voltage, high amperage, and a tissue response system. Whereas the instrument, which are held in the hand, should have a high pressure, should be open, and of course, laparoscopic. So these vessel sealers have had a fairly long history, and they've had quite an evolution, comparable to, say, humans have over many, many years. And in fact, it started towards the late 1980s, the early 2000s, where these devices underwent a rapid evolution or rapid innovation, and became actually much more safer, much more easy to use, and now, of course, are sort of standard of care in a lot of centers across India. So essentially, just for an example, an ultrasonic device eventually had to started from a very basic mechanism, expanded to an advanced bipolar system, and actually combined the ultrasonic with advanced bipolar generators. And now, of course, we have an array of instruments both for open surgery as well as endoscopy. In fact, we also have articulating instruments. So this has undergone many years of advancement that has actually resulted in very efficient instruments. So actually, why do we need vessel sealers is the next question. And most of, whenever we do a surgical procedure, one of the foremost things in our mind is actually trying to control blood loss and trying to perform that procedure efficiently and without compromising on patient safety. So there are various surgical burdens that are now there for the surgeon in today's day and age, associated with tissue dissection, tissue sealing, using various energy devices. So there are bleeding complications, can be tissue damage, and of course surgical smoke, for instance, with monopolar energy. So this uncontrolled bleeding during a surgery can lead to complications, can lead to increased morbidity, can even have the patient to be shifted to the ICU, can basically cause the patient to extend their hospital stay. So as I said, bleeding complications occur in roughly 7 to 13% of surgery. It can actually lead to a financial burden, not only for the patient, but also the hospitals. The bleeding can also increase over time. So whenever there's a surgical procedure that is taking time frequently, as most of you all might have noticed, the entire surgical list gets delayed, and sometimes patients that have to be taken at the end of the day will have to be shifted to the next day or the next week. So better outcomes are actually a shared goal of not only the patient, but also the doctor. One has to reduce bleeding. One can improve the OR safety with these vessel sealers and actually reduce the OR time and length of stay. So as I said before, all these actually improve uh, the condition of healthcare in a nation. Now we'll start off with the types. The first is ultrasonic. So essentially what ultrasonic does is it unwinds the amino acids and reshapes hydrogen bonds, resulting in the coagulant to be formed. It basically contains these piezoelectric discs that convert electrical energy into mechanical energy, which is amplified by the silicon element. These vibrate at a fairly high frequency, more than 55,000 hertz along the axis. And as I said before, it employs both compression as well as friction to deliver the mechanical element. Now, these, of course, are frequently used by many surgeons across the country and are available in a device that looks just like this. They, of course, have a rotatory adjustment at the proximal end, which adjusts the blade direction, as well as various trigger buttons and a jaw, sort of a handle that can close the jaw. So in an ultrasonic generator, there are two settings available. There's a maximum and a minimum. The maximum has mechanical energy delivered at the greatest. So you have oscillations of the shaft, which has rapid tissue transection. So this is basically similar to the cut. And the minimum is more of a coagulation, a low mechanical energy delivered. You have smaller oscillations and is ideal for vessel sealing. So this is just a brief about or image about what the previous slide was. You have, of course, an articulating jaw, which is the dissector, and a non-articulating or the active jaw. This, as you know, people use it as I was taught. One should be very careful as to what one is, where one is touching the active jaw. Always keep it under vision, so one doesn't touch neighboring structures like the bowel. Now, of course, these devices are available with varying lengths. It depends on what one really has to use. And of course, these have the ATTs or the adaptive tissue technology. Now, another sort of a cousin of this is the N-Seal, which is available. It has been postulated to have better hemostasis, a longer jaw, has less thermal spread, and is available with 360-degree rotation. Now, having used both of these, I feel that the N-Seal is good for these larger vessels, but for tissue dissection and for better, say, for example, bladder dissection, I prefer the harmonic. So the N-Seal adjusts energy according to tissue impedance. Again, it has a smart electrode technology. It has a number of nanoconductive particles, and each particle basically interrupts the current flow to a specific tissue when temperature there. If temperature falls below the fusion level, the particles turn back on. So this is sort of an image of that jaw. These vessels, the N-Seal are vessel sealers that have a fairly robust and large jaw. And once the vessel is sealed, one has to sort of press the handle, and there is a blade that actually cuts this tissue apart. So these are good, for instance, for uterine arteries or any large vessels that have to be transected. Again, at the close to the handle, there is an ability to rotate the blade by about 360 degrees, depending on what the angle of the at what position the vessel has to be sealed. So it's fairly easy to use, but of course it is a little heavy in the sense that it's heavier than some of the other vessel sealers. So one has to have a slight adjustment, but I think once people get used to it, it's quite convenient to use it. So just to summarize, there's less heat required. The tissue volume is reduced by compression. Again, there is protein denaturation and renaturation. It seals up to 7 mm vessels, and the thermal spread, the lateral thermal spread, is just about a millimeter or so. So it withstands up to 7 times the systolic pressure. So it has a very good seal quality. Now, this, of course, device is used in a number of instances for bowel resections, for hysterectomies, even in other surgeries, for example, gallbladder or cholecystectomy. Adhesiolysis is another thing where gynecologists can use. We next move on to ligature, which actually has what happens in ligature is that there is a hydrothermal rupture of collagen cross-links. The temperature is about 60 to 90 degrees Celsius, and it is the electrosurgical collagen welding combination of pressure and energy. So there's both here, denatures that collagen and elastin to form a permanent seal. This is just a short video just to show an animation of how this device works. The vessel seal is done, and once that seal is done, there is a cutting blade that cuts that tissue. So this is just the device which is there. It has a fairly decent ergonomic control. Some may like it, some may not, but it's one of the popular vessel sealers available. Now there is again a uniform compression. There's a very fairly low lateral spread, and there is an audio signal to signify that the sealing process is over. Now, ligature has basically the cooling allows the renaturation of the untangled unwound collagen strands. It permanently fuses the tissue and the vessels without actually desiccating them. And the high uniform mechanical compression increases the entanglement upon the thermal relaxation. So just a histological picture of what actually happens in a vessel seal. There is, of course, a blood pocket which is formed, the sealing area, as I mentioned before, as well as the denatured collagen, which is there in the adventitia of the vessel. There is also gas formation that occurs. So this is just the histology of vessel sealing. So again, it can ligate vessels up to 7 millimeters. The seal can withstand up to 3 times the normal systolic pressure. So it's a fairly decent vessel sealing device. And again, has feedback control response system. So basically, there's a cycle, and this cycle exists in this device. So this device also has a silicon nano coating, which basically is the benefit of this is so that the tissue doesn't stick. So it has non-stick capabilities and is available in a various types of instruments. Now, we'll skip this. The next device is the Thunderbeat, and basically it is has 2 types of action. The first is an ultrasonic action, and the second is a bipolar. So basically, it is a single device simultaneously delivering the ultrasonic generated frictional heat energy, like the harmonic, and also like the bipolar, has an advanced bipolar energy. So it has higher burst pressure and basically reduced lateral thermal spread, and there is no blade required for cutting. This is the Thunderbeat. If you look at it closely, it's basically, they describe it as the viper jaw because it looks like the snake. And this basically is able to give a fairly strong compression so as to enhance that vessel seal. And it also has that fine jaw that helps in tissue dissection. Now, of course, in the robotic surgical system, with the XI and some of the other systems like the X, they have these robotic vessel sealers, and they are essentially of 2 types. One is the Extend, which is on the E100. They have fairly lower temperature and only about 1 to 2 millimeter lateral spread, and have a faster, they cool down much faster. There's also the Synchro Seal, which seals up to 5 millimeters. So this is just video showing the 2 types of vessel sealers, the Synchro Seal on the left and the vessel sealer on the right. So here, for instance, it helps in doing an omentectomy, and one can see that both these vessel sealers are fairly efficient in their action. So when you look at the comparison, we first have to understand what exactly is burst pressure. So you can compare it on various parameters. The first is, of course, burst pressure. So the burst pressure related to the vessel's sealing thread. Now, the maximum intraluminal pressure that is within that vessel is achieved before leakage occurs at that site. So basically, you want more burst pressure. And this is all from literature. And usually it states that the ultrasonic devices are somewhere in between, and the ligature is higher than that ultrasonic device. Now we look at the mean seal time, that is the average amount of time required to seal a vessel. And here again, the ligature and harmonic are fairly good at what they the mean seal time. Now, mean failure rates are of course low in case of ligature and the ultrasonic device. This, of course, is data from a few years ago. Now, if you look at if you compare these on a table, one can see that the vessel seal for an ultrasonic device which is available is only about 5 millimeters, whereas for other devices like ligature it is a little higher. The cutting speed of the ultrasonic is a fast one compared to the others. Here again, the burst pressure is fairly high with Thunderbeat as well as the ligature. The base action is, of course, a seal cut with a harmonic, the seal independent cut with a ligature. The lateral thermal spread, as I said before, is quite low in case of ligature, Thunderbeat. Ergonomics are fairly good in all three, maybe a little better with an ultrasonic device. Now here's a video that essentially shows an infrared video which shows the heat generated in both these vessels. So you have an ultrasonic device on the left. You have, and it actually shows that in an ultrasonic device, there's quite a significant amount of heat that is generated in the jaws. So one has to be very careful when using these vessel sealers and not keep touching any adjacent structures like the bowel or the bladder. Now, literature related to comparison of efficacy safety is not very easy to find. There aren't so many articles on that where they've actually compared these two in Dynac procedures. In some of the other specialties, there is a little more literature, but that is a little difficult to find. But personally, in practice, whether it is endometriosis and looking at the torus or the rectovaginal septum, I personally use the ultrasonic device. I find that fairly easy to use. Also, if I have to do a cystectomy, these are quite good in endometriomas, whether one is doing parametrectomy, and of course lymphadenectomy in case of malignancies. I've also used the N-Seal, which is fairly good to use in case of adhesiolysis, especially if there is a vascular pedicle or vessel which is there. The blade is quite convenient to use. And of course, now the generation 2 articulating forceps are also articulating vessel sealers are there. They do actually help in accessing, a certain anatomical structure on the contralateral side if one is, say, an ipsilateral surgeon. But other than that, there's not really much benefit in these articulating sealers. But the N-Seal itself as a technology is quite good. However, for bladder dissection, I prefer the original ultrasonic device. However, usually when I operate with just an ultrasonic device, I always have a bipolar instrument in the left hand to sort of seal off a vessel in case the ultrasonic cannot. Here just shows bladder dissection with and that's all. Thank you so much. for your time.
That was a fantastic talk, Dr. Gaurav. Very nicely, all energy sources, everything you described so much in detail, all vessel sealing. I'm sure it must be good help to everyone. And we have a very nice, big audience that was listening to your lecture. So thank you very much for this deliberation. Very nicely.
Thank you, madam. Thank you.
Thank you. Yes, Vaishali.
Thank you, Dr. Gaurav. Yeah, excellent talk. And I was just remembering, you are an associate professor at KEM, and when we were students at KEM, Sir has taught us, Dr. Shyam Desai has taught us, and I think similarly your students must be also learning from you and benefiting hugely from your expertise. So thank you so much for being here today with POGS and giving a fantastic talk here.
Thank you, Dr.
So,
Vaishali.
Dr. Nilesh? Yes. So I think Sudha ma'am will not be able to speak. So this has been a wonderful collaboration with MOGS and POGS, and we at POGS are absolutely really very happy and grateful for doing this with the big society. And like Dr. Preeti said, this is sort of like an exchange webinar. So I think we would like to call that. Dr. Preeti, we met at the last exchange conference at Dela Resort, right? That was 2 years ago. So today feels like an exchange conference because it is at the end of the year that we have come of our year
Yes.
where we'll be handing over to the new team. So Dr. Meenu, would you like to say something more
Yes.
before we end the
Instead of calling it a webinar, calling it an exchange conference webinar. So it will be nice.
Yeah, I think we will need to do that. So we will have exchange minis and majors. The minis are here and the majors will be at Dela or
Yeah, so it was nice. We had 2 speakers from MOGS, we had chairpersons from MOGS, and also the chief guest from MOGS, and of course, we had from Gujarat Society, we had Dr. Sanjay Patel and Dr. Neeraj Yadav. So it was a very nice collaboration of various societies and good audience as well. And thank you very much. Thank you, Madhura. Thank you, Charu. Thank you, Vaishali, for taking this so religiously, so with so much of discipline and so much of dedication that these webinars are going week after week. And every time before the one gets over, I keep getting messages, when is the next cutting edge webinar? What are the topics? Because we are just trying to choose good topics for everyone. So I'm sure people who are listening can also suggest the topics that they would want to be added into this webinar, and we will be very happy. And Gaurav, your talk, cutting edge, actually went very well with cutting edge technology. So thank you very much. Thank you everyone for
It's
joining.
my pleasure to propose a vote of thanks. So I would like to first of all thank President POGS Dr. Meenu Agarwal and President MOGS Dr. Anahita for the joint collaboration. Thank you to our chief guest Dr. Nandita, guest of honors Dr. Sanjay Patel and Dr. Neeraj Yadav, and to all the speakers Dr. Meenu Agarwal, Dr. Preeti Vyas and Dr. Gaurav, and for all the chairpersons as well. Dr. Ganpat Sawant, Dr. Gautam Sonawne, Dr. Sudha Tandon, and Dr. Nilesh Balkaude, along with Anahita Madam and Dr. Pratik Tambe. I would like to thank SV for doing these webinars with us every weekly. And young Madhura, Dr. Madhura, who has been very helpful. And that's how these webinars are running very smoothly. I would like to thank all the delegates who have logged in today with us. So thank you very much. Thank you all. Thank you.
Thank you, everyone.
Thank
Thank you, Dr. Yes, thank you.
Thank you.
Thank you very much. Thank
Let
you,
me stop
Mr.
recording.
Prasad, for keeping you, sometimes working on Saturdays and Sundays, always on weekends. So thank you very much for putting up with us.
Chalo, bye ji. Thank you.
Thank you, madam, for
Bye.
involving me. Thank you. I couldn't
Thank you,
speak
Lily.
when you called me, just was a patient in front of me. Sorry, madam.
Yeah. No problem. I read your message later on because we were winding up.
Ellen, stop
So
recording now.
Recording stopped.